Thank you, Jen Childress. We're now ready for session 3. I'm excited to have Juliana Crawford, National Executive Vice President for Emerging Strategies at the American Heart Association and a National Forum Board member, as the moderator for this panel. She'll frame the session and introduce our speakers. Juliana, thank you for leading this important discussion. The floor is yours.
Okay. Okay, well, I will start by introducing our panelists. First off, we have Dr. Yvonne Commodore-Mensah. Dr. Commodore-Mensah is Associate Dean for Research at Johns Hopkins School of Nursing and Johns Hopkins Bloomberg School of Public Health in the Department of Epidemiology. Next, we have Dr. Ann Carroll Goldberg. Dr. Goldberg is a professor of medicine at the Washington University School of Medicine. And then we have Dr. Rashmi Shah. Dr. Shah is adjunct professor in cardiovascular medicine at the University of Utah School of Medicine and also a clinical research scientist at Meta. And then finally, we don't have Dr. Michael Knight with us live today, but we have pre-recorded his session. Dr. Michael G. Knight is Clinical Associate Professor of Medicine at the George Washington University. And we'll begin by hearing Dr. Knight talk with us about obesity in his pre-recorded discussion.
Thank you. I'm excited to really discuss how obesity plays a role in this conversation. As we all know, obesity is a global public health crisis affecting over 650 million adults worldwide. But we also know that it's much more than just numbers on a scale. Obesity is a chronic, relapsing, multifactorial disease that increases the risk of several serious health conditions, some of which we've already heard in our panel. Whether we're discussing cardiovascular disease, we know that obesity contributes to hypertension, atherosclerosis, and heart failure. And we know that it's not just the metabolic process, but we know that there's levels of inflammation and lipid abnormalities that are playing a role here. Type 2 diabetes, which many times their term is called diabesity because of the close correlation to patients who are struggling with type 2 diabetes and living with obesity. Obesity is the strongest risk factor. About 90% of people with type 2 diabetes are overweight or living with obesity. We know that adipose tissue increases insulin resistance, disrupting the glucose metabolism. And so addressing diabetes often goes hand in hand with addressing obesity. And finally, chronic kidney disease. We know that the direct and indirect contributors to kidney damage is related to living with obesity. And then, of course, diabetes and hypertension also involved. So when we talk about addressing cardiometabolic disease, obesity has to be a part of the conversation. But where are we today? We know that there are a number of strategies to treating obesity effectively. But what we know is that a comprehensive strategy is what we use to see success. The foundation of that strategy is diet and physical activity, lifestyle changes. No matter what new medications we have, lifestyle is still the core. And so when we think about whole food diets, caloric restriction, sustainable physical activity, and really thinking about how we interact with food and how we interact with things like super processed foods or foods with poor nutritional quality, we know that that is core to that work. But then we also know that for the majority of patients, over 94.5% of patients who want to achieve long-term weight loss, and specifically those living with obesity, class 1, 2, and certainly class 3 obesity, that's not where the story ends. So additional interventions such as medications. We now are in an era where we have highly effective medical treatments that work to supplement, right? Not replace, but supplement lifestyle interventions. And so whether we're talking about the most recent GLP-1 receptor agonists that like semaglutide or tirzepatide that really lead to 15 to 20% or more of total body weight loss, significantly improving metabolic health. But we also are starting to see weight independent effects on things like cardiovascular disease risk reduction and also liver health. Particularly with MASH. We know bariatric surgery still is a part of the conversation for many patients and improves or resolves type 2 diabetes, reduces cardiovascular mortality, and slowing kidney disease progression. But what does the future hold? We will continue to see highly effective medications with 25% or more total body weight loss. We know that technology, whether it's AI, wearable apps, AI coaching, are going to make obesity treatment more personalized and support lifestyle interventions, but also policy and prevention. So how do we do that early intervention for our youth? How do we prevent obesity? And how do we have coverage for patients, particularly those who are most in need for these treatments? So again, a holistic approach is key. It's more than willpower. It's a complex interplay of biology, environment, and behavior, and combating diseases like diabetes, cardiovascular disease, and chronic kidney disease cannot be done unless we address obesity as a root cause.
Those are great points. A great introduction to obesity and how the interplay with cardiovascular disease. And certainly we know how much of a risk factor diabetes is for cardiovascular disease. And you tied that together with obesity. So thank you for that great overview, Dr. Knight. We're at a moment right now, I think many of us in cardiovascular disease and certainly in prevention feel like we're constantly struggling to get people's attention on the opportunities to prevent the leading cause of death, heart disease and stroke. And often it's because there's some shiny new object out there that has everyone's attention, and it's pulling that attention away from this huge opportunity to prevent cardiometabolic disease. Now, though, GLP-1s, which you mentioned, they're part of the reason why there's intense attention on obesity and weight loss and how it connects to other facets of health. And I'm wondering what your thoughts are on how we can seize this moment to increase the attention on and enable more people to benefit from these innovations and from the new attention on obesity as a way of also preventing heart disease, stroke, diabetes, and kidney disease, which you mentioned.
Yeah. So I think one of the ways that I think about this is I think about residual risk, right? So we know we have effective treatment regimens and recommendations for a patient who has cardiovascular disease, whether it's atherosclerosis, they've had a MI in the past, they've had a stroke. We know the statin therapy to put them on. We know the aspirin to put them on. We know those other medications, but there's still a level of residual risk that is there for our patients. We can all think about a patient that we've gotten them on the full treatment regimen, and unfortunately, they have either a poor outcome from the original event or a recurrent event, whether it's a stroke or a heart attack, that lead to poor health outcomes. So obesity is a large piece of that residual risk. And so treatments like GLP-1s that can not only reduce obesity, but also may have a weight-independent effect on reducing cardiovascular disease can further reduce that residual risk. And that, again, gives us more tools in our toolbox to reduce and improve overall cardiovascular disease outcomes.
So, Michael, we know there's not only attention, but there's really high demand, consumer demand for the semaglutide and tirzepatide. And yet I wonder, is everyone who could benefit from it getting it? Are they able to take advantage of these innovations? And if not, what could we be doing so that everyone who could benefit has access?
Yeah, so unfortunately, no. We know that the majority of patients living with obesity are not getting a treatment. Less than 3 to 5% of patients living with obesity are being treated. And so that's a combination of factors. There's access, so insurance coverage, cost. We know that many of these medications are high cost if they're not covered. And even with coverage, the copays may be very high. So addressing the cost, access, advocacy. We know that, for example, Medicare does not cover treatments that are specifically to treat obesity. And so how do we evolve that thinking that this is not a cosmetic issue, this is a medical issue, to open up access? But then even when you have access, healthcare providers have to also be on board and not waiting for a patient to deserve treatment. Right? We don't, when a patient shows up with elevated blood pressure, I don't say, well, I'm not going to treat you because you just had that high salt meal last night and you don't deserve the medication. Right? It's a part of a comprehensive strategy. So yes, I'm going to counsel you so that you're not having those high salt meals, but I'm also going to treat you. And that same approach is needed in obesity.
Wow. I wish we could have a whole panel on what you just said, because the role of judgment, judging patients, is so important as we wrestle with gaps in care between various populations. But let's hold that for a different briefing or a different convening. Right now, I'd like for us to look out on the horizon. We have these really powerful GLP-1s available today by injection, and we know that in the not too distant future, there probably will be oral versions. They're in the R&D pipeline. How will that change the environment, and how might they change the landscape for obesity and heart disease prevention?
Yeah, well, the benefit there is that we offer more options, right? There are more options for patients. Obviously, there may be some patients that prefer to have an oral agent, so you have that opportunity, but hopefully cost is also going to be improved. We know that there's a supply and demand, right? And so as we have more options, we're hoping that we see the price come down. So I think that if oral options are more accessible and affordable, but also aligned with patient preferences, we're going to see much, much more opportunity to treat obesity and reduce cardiometabolic disease.
And what role does patient preference play in outcome success?
Yeah, it plays a big role because obesity is a chronic condition. This is not a one and done. Many of these treatments are chronic treatments. And so it has to be something that makes sense to the patient long term. It's not, I'm just going to do this for 6 months and then I'm going to go back to what I've been doing. So if they have to be comfortable with administering these medications, with making these lifestyle changes, with having a new approach to physical activity and diet that they can maintain long term. And that is why patient preference is so important. It's not a one size fits all. I have to listen to the patient, understand what their values are, understand what is workable and sustainable for them, and then come up with a comprehensive treatment plan that makes sense. So that patient partnership is so important when we are treating chronic disease.
Dr. Michael Knight, thank you very much for an informative and dynamic presentation and conversation. Now we'll turn the microphone back to Juliana Crawford and the panel.
Okay. All right. We're going to begin with Dr. Commodore Mensah, who's going to talk to us about hypertension.
Good afternoon, everyone. It's such a pleasure to be invited to provide an overview of the most recent 2025 high blood pressure guidelines. First, I'd like to acknowledge that this work was done by 29 clinicians, 4 clinicians, and in collaboration with 13 different societies focused on the prevention, detection, evaluation, and management of high blood pressure in adults. Here's the problem. Unfortunately, approximately 120 million Americans have high blood pressure. We also know that high blood pressure is a leading risk factor for cardiovascular disease, stroke, kidney disease, and there's so much more we can do to control blood pressure. Now, we know that according to national data from the National Health and Nutrition Examination Survey, less than 1 in 4 U.S. adults have their blood pressure controlled to less than 130/80. This is a problem because we know that controlling high blood pressure prevents cardiovascular disease, stroke, and kidney disease. In the most recent 2025 guidelines, we have more evidence that controlling blood pressure is linked with brain health. So in 2017, there's a recommendation that blood pressure lowering may be reasonable to prevent cognitive decline. However, in the 2025 guidelines, we have stronger evidence that in adults with hypertension, a goal of less than 130 systolic blood pressure is recommended to prevent mild cognitive impairment and dementia. So now we have another reason to control blood pressure even more strongly. So the take-home message here is intensive lowering of blood pressure reduces the risk of cognitive decline and dementia by 15%. Now, when it comes to controlling blood pressure and managing blood pressure, there are things that we need to consider in terms of treatment thresholds and the goal. One thing that is unchanged is the fact that normal blood pressure is still considered less than 120 and 80. So systolic blood pressure has to be less than 120 and the diastolic has to be less than 80 to be considered normal. A new addition in the 2025 guidelines is the use of the PREVENT equation, and I'll talk more about that in the subsequent slides. However, the goal for blood pressure control for adults with hypertension is less than 130 millimeters of mercury, but a new addition is that it is encouraged that in adults who can tolerate more intense blood pressure control, we should be treating blood pressure to a goal of less than 120 millimeters of mercury. Now, this is because we have more robust evidence that intensive blood pressure lowering reduces the risk of cardiovascular disease, kidney disease, and as I mentioned earlier, cognitive decline and dementia as well. In managing blood pressure, we also consider an individual's risk for cardiovascular disease. One thing that has not also changed is that lifestyle modification is a hallmark of blood pressure control. So for all adults diagnosed with hypertension, we need to focus on lifestyle modification, but also in preventing hypertension in the first place, lifestyle modification is effective. For individuals with stage 1 hypertension, we need to use the PREVENT equation, which estimates the 10 and 30-year risk of cardiovascular disease, and that's shown on the right side of the screen. For individuals with stage 1 hypertension who also have a history of cardiovascular disease, stroke, kidney disease, or diabetes, it's important to start medications promptly if someone has what we consider stage 1 hypertension. For adults with stage 2 hypertension, again, lifestyle is a foundation, but we also need to use medications that have been proven effective and start with at least 2 drugs in a single pill combination. And this strategy likely improves adherence for patients who are diagnosed with hypertension. Now let's transition to what's new. As I mentioned earlier, lifestyle modification is a hallmark and foundation of blood pressure control. So the guidelines emphasize the importance of blood pressure control through lifestyle modification. But a new addition is the inclusion of potassium-based salt substitutes as an addition to the strategy to improve blood pressure control. Now, this could be considered in specific patients who don't have any evidence of chronic kidney disease or are not taking other medications that may affect their potassium levels. Another addition in the 2025 guidelines is the focus on controlling hypertension during pregnancy. Now, in the US, we know that we have a very high maternal mortality rate, and cardiovascular disease is one of the causes of this high mortality rate. And controlling hypertension during pregnancy will ultimately reduce mortality from cardiovascular disease. The guidelines emphasize that for pregnant women who have blood pressure, a systolic blood pressure greater than 160 or diastolic greater than 110, we should manage blood pressure and they should receive antihypertensive medications to lower blood pressure to less than 160 over 80 within 30 to 60 minutes to prevent complications. Now, for individuals who have hypertension prior to pregnancy, or what we call chronic hypertension, it's important that we prescribe medications and they receive antihypertensive therapy to achieve blood pressure control of less than 140/90. Now, for individuals who are planning pregnancy or become pregnant and have hypertension, it's important to also consider the use of low-dose aspirin to reduce the risk of preeclampsia during pregnancy. As I mentioned earlier, we have effective strategies in our toolbox to control hypertension, including lifestyle modifications and medications. But what's also new is the use of renal denervation in carefully selected patients. In the 2025 guidelines, there's a Class 2B recommendation to consider renal denervation among patients who have resistant hypertension. So in addition to the 2B recommendation, there are also recommendations for how to manage resistant hypertension. So considering what we define as resistant hypertension, we need to also evaluate patients carefully for secondary causes of hypertension and remove all medications that may interfere with their treatment. And in also considering who would benefit from renal denervation, that evaluation should happen with a multidisciplinary team. So this is a Class 1 recommendation, and this should include experts with expertise in resistant hypertension and renal denervation. Another Class 1 recommendation, which is the highest level of recommendations, is also to use shared decision-making. The decision to use renal denervation among patients who have resistant hypertension or uncontrolled blood pressure on multiple medications should be done by having a conversation with the patient and coming to a shared decision about the benefits and also the risks associated with the procedure. What's also exciting is that we know that there are new treatments on the horizon to treat primary aldosteronism. This is effective in individuals who may have higher levels of aldosterone. And so this treatment will hopefully reduce aldosterone levels and hopefully also help to control blood pressure. Now, in wrapping up our conversation, it's also important to consider that if we want to improve blood pressure control, we need a plan. Blood pressure control doesn't happen by chance. And so the guidelines also emphasize that multidisciplinary team-based care is effective in assessing and addressing patient access to medications, but also other structural barriers that a lot of people may be affected by, and addressing these barriers to achieve blood pressure control. Now, there are also other tools that help to promote blood pressure control. Home blood pressure monitoring is one of those strategies. Home blood pressure monitoring, in addition with clinician support, helps to control blood pressure. And this is accomplished by engaging multidisciplinary team members, including physicians, nurses, community health workers, pharmacists, and also by using a standardized measurement protocol. We need to measure blood pressure accurately to be able to obtain accurate results, and also using treatment protocols. Treatment protocols have been shown to improve blood pressure control, and all of this should be considered in an integrated fashion to improve rates of blood pressure control. Now, the guidelines recommend against the use of cuffless devices that are now very popular because we don't have enough evidence on the validity of these cuffless devices. Now, if you must purchase a blood pressure cuff or a device, make sure that it's appropriately sized and don't rely on cuffless devices because we need more information on the precision and the reliability of these devices. In closing, there's something all of us on this call can do to put hypertension on the map. For clinicians, we need to use validated blood pressure devices and follow proper technique. We also need to act rapidly to control blood pressure and also set very clear goals for our patients. We also need to practice shared decision-making to improve blood pressure control. For policymakers, we need bills and laws that support reimbursement for home blood pressure monitoring and also to improve access to clinicians to improve blood pressure control. We also need to eliminate barriers to access to these effective medications and therapies to improve blood pressure control, and also consider how we can provide treatment programs that will be available to most Americans. We also need to support and community health workers and write bills and laws to reimburse the care that community health workers provide. And for community members and leaders on this call, we need to improve awareness of hypertension and provide community screening events and work in partnership with clinicians and health systems to manage blood pressure. And we also need to promote awareness of lifestyle modification also as a hallmark in preventing and managing blood pressure. And for patients and everyone on this call, there's something we can also do. If you are diagnosed with hypertension, please do monitor your blood pressure at home. Please do purchase a validated device to measure your blood pressure and share the readings with your clinicians, and have a conversation with your clinician to see what the best plan of action would be for you to control your blood pressure. And also share any concerns with your healthcare team, and make the conversation about hypertension control a family conversation. Talk to your loved ones about managing blood pressure and things that all of us can do to reduce the burden of hypertension in the U.S. Thank you.
That was great, Dr. Commodore Mensah. Next up, we will have Dr. Goldberg talk with us about the lipid space.
Okay. I want to thank John Clymer and the National Forum for asking me to speak this afternoon, and I'm going to talk about lipids. So what's the problem? The problem is that high levels of LDL cholesterol, people call it the bad cholesterol, increase the risk of atherosclerotic cardiovascular disease, leading to heart attacks, strokes, and other vascular problems. And you can estimate that about 90 million U.S. adults aged 20 and over have cholesterol levels over 200 milligrams per deciliter, and 25 million have levels over 240 milligrams per deciliter. In addition, a fairly high percentage of children, some 10%, have high cholesterol levels. 1 in 300 people have familial hypercholesterolemia. This is inherited high cholesterol, leading to increased risk of cardiovascular disease because the high cholesterol levels start from birth and accumulate throughout the lifetime in terms of their effect on the vasculature. However, risk can be decreased with lifestyle to start. It's our main foundation of treatment, and this includes a healthy diet with the current and really well-established information being that lower saturated fat intake lowers LDL cholesterol, and one replaces saturated fat with unsaturated fat, poly and monounsaturated fats. Exercise helps, adequate sleep, controlling blood pressure and diabetes, and particularly avoiding tobacco use, and stress reduction. Most people respond to lifestyle changes, especially diet and treatment of obesity. However, many people need medication and are not started on medication. Our mainstays that have been around now for decades include statins and ezetimibe. Ezetimibe blocks cholesterol absorption, whereas statins decrease cholesterol production. And the combination of these two generic medications, almost all the statins are generic, will get most people to their LDL cholesterol goal. We have new medications. Some have been around for a while, and some are even newer, particularly the PCSK9 medications. So PCSK9 is a protein that affects the uptake of LDL by liver cells and all cells in the body, but particularly in the liver. And we have medications that decrease the production of PCSK9 from the liver, as well as medications, monoclonal antibodies, that block the interaction of PCSK9 with the LDL receptor, the molecule on LDL, on cells that leads to uptake of LDL, removal of LDL from the blood. In addition, we have new triglyceride-lowering medications for people with very high triglycerides in the range of 1,000 and up that put them at risk of pancreatitis. And at least one of these has been approved for people with a severe genetic problem of hypertriglyceridemia. In addition, we have medications for the most severe form of inherited cholesterol. People who have homozygous familial hypercholesterolemia, that is, they have abnormalities in two alleles that lead to LDL cholesterol levels over 400 milligrams per deciliter starting at birth. And these numbers can get up really high with total cholesterol levels up to 1,000. People who are severely affected have very early cardiovascular disease, and we can now use a combination of medications to treat them to prevent their heart attacks and strokes. The other really interesting area right now is lipoprotein(a). So lipoprotein(a) is an LDL-like particle with an attachment called apolipoprotein A. This is only found in great apes and humans and in European hedgehogs for some reason. Elevated levels of lipoprotein(a) cause atherosclerosis, and high levels are associated with increased risks of heart attack and stroke, as well as with an increased risk of aortic stenosis, that is, narrowing and calcification of the main valve leading from the heart. 1 in 5 people have levels above normal, which means that this is a large number of people worldwide. Diet and exercise do not work. The current approach to treatment is to lower the LDL cholesterol and control other risk factors. And we do this with medication, diet, and controlling other risk factors, such as not smoking. There's also a treatment which is apheresis, which is a direct removal of LDL and lipoprotein(a) from the blood, but is not available everywhere, is time-consuming and expensive. However, new treatments are in development, so there are a number of cardiovascular outcomes trials underway with injectables that lower production of apolipoprotein A, so you get a marked decrease in lipoprotein(a) levels. These include pelacarsen, which is an antisense oligonucleotide injected once a month, and several mRNA silencing medications that are also in clinical trials. There's also an oral medication that prevents the formation of lipoprotein(a), so it keeps apolipoprotein(a) from attaching to the LDL-like particle. So this is very exciting, and the first of the cardiovascular outcomes trials will be reporting out next year, 2026, and hopefully that trial being positive will lead to the availability of these medications for people who are at high risk. However, we still have a lot of problems. So we are not measuring lipid levels. We're not measuring LDL. We're following up in many people, including measuring it in children, many adults, and even people after heart attacks and strokes are not either having a measurement done or a follow-up measurement to see how they're doing and whether they're at goal. Many people needing treatment are not treated. So we have lack of access to care, misinformation about diet, misinformation about medications, a very long delay in the uptake of guidelines. In fact, the recommendation for universal screening of lipid levels in children aged 9 to 11 came out in 2011 from the National Heart, Lung, and Blood Institute and the American Academy of Pediatrics. What can be done? Well, we need information campaigns to inform people about lipid levels. They should know their cholesterol. They should know their lipoprotein(a) levels. Lipoprotein(a) only needs to be measured once in a lifetime. We also need the availability of more free testing. There are free tests available from some organizations. It's possible to actually get one's own test done through some of the national labs. Relatively inexpensively. We also need access to care. So we need funding, we need insurance coverage, and this is a major problem right now. The availability of generic medications can get most people to goal, including the statins, which work extremely well and we've had for over 30 years. The current feeling among people doing lipids is that longer and lower is better for LDL. We need to start younger to prevent the buildup of plaque in arteries. We could even prevent the problems from occurring. If we could prevent the plaque from developing through lifestyle and medication, this would decrease the numbers of strokes and heart attacks, which would lead to enormous cost savings financially, societally, and for the individual to decrease pain and suffering. Thank you.
Thank you, Dr. Goldberg. Next, we'll have Dr. Shaw talk to us about the role of technology.
All right. Wonderful. Thank you guys so much. Great to be here. I am going to shift gears here a little, and I'm going to make some speculations about the future. I think there's a lot of exciting technology on the horizon, and really the question is, how are we best going to harness that to address some of the challenges? So if I pick up on a couple of the other speakers' comments, Yvonne said that 120 million people in the US have high blood pressure. And Anne said 90 million people have high cholesterol, and many people are not checking their cholesterol, and the guideline uptake has been slow. So these are challenges we need to address, and I think it's possible that technology can help us address some of these challenges. So what I want to do is talk about kind of different threads of technology that can now be strung together to help scale what we do. So if you take a look at this image, these are some of the puzzle pieces or variables in the equation, going from left to right. So first, we have digital health platforms. So you can think of that as the wearables. You see probably everybody has a different type of, many people have different types of watches. And I'll mention a few companies, but I don't have any stake or relationship to those companies. So for example, the Apple Watch has the sleep apnea detection, now a hypertension notification. The Oura Ring has many different biometrics. The Whoop Band has stress recovery, apnea, and now they actually have a blood pressure notification, which the FDA is challenging. But all of these wearables are collecting biometric data about their users. But the other thing they're doing is building platforms. So platforms are a place where data gets aggregated in reusable ways and allows sharing, essentially. So if you build a platform, a health data platform, people and apps and enterprises can build additional features on top of that platform. So like one important way this field is evolving is that these platforms are now collecting different types of data. So for example, Whoop has their biometric data, but now they have something called advanced labs. So users can pay a subscription fee and they partner with Quest Diagnostics and they can go get their blood test. In the app, they can request a blood test and they can go to a Quest lab and get that checked. So you can go get your cholesterol checked through the app. Oura Ring has something similar. It's called health panels. And these are essentially creating platforms that we can then build off of. So the next piece of this equation is the LLMs, evidence-based LLMs, large language models. I think people might be familiar with this because of the popularity of ChatGPT, which is a large language model. Users can input a prompt or a question, and the model will return human-like text to answer that question. Now, there are specific medical and health-related LLMs. One example here is Open Evidence, where you can enter a question and it will give you an evidence-based response. So, for example, if you look at the Whoop website, they show an image of a woman who's checked her labs with their advanced labs, and she has a high CRP. So I took this and I said, okay, if I gave this to Open Evidence, what would it do? So I put a 45-year-old, otherwise healthy woman has a high CRP. What should she do? The LLM said, they gave me sort of four pieces of the response. One is high CRP is associated with cardiovascular risk. Lifestyle is the cornerstone of intervention. Your doctor might choose to do a 10-year risk based on the ACC-AHA equation. And they might consider additional coronary CT score to risk stratify for statins or other interventions. This was correct. They provided references. This computer model gave the correct answer. So hopefully you can imagine how these pieces of technology will string together to allow users to collect their health information and then understand and do something about that information. The final piece of this equation is generative AI. So Gen AI is a huge field. The example I'm going to use here is how can we use this technology to deliver information to an end user or a patient? So for this little experiment I did here, I took the response from Open Evidence's LLM, this about the CRP. I put it in Gemini, which is Google's model, and said, can you make this in some simpler language that a layperson can understand? And then I took that as a prompt and put it in Sora. So Sora is ChatGPT's most recent video generation model. I said, using the likeness of me, deliver this message. And this is what it did. So a computer generated this. I did not videotape myself saying this.
High CRP levels indicate inflammation and may signal future heart problems. If your risk is high, a doctor might recommend a coronary artery calcium scan for more information. Statins may also be recommended.
So hopefully this allows you to see how technology can be joined together to deliver an experience and important information to an end user. And there's one more piece of the puzzle that I think is worth mentioning, and that's the money. Who's going to pay for all this? So I think in 2025, an interesting thing happened. In the One Big Beautiful Bill Act, it passed in July. That legislation said that HSA, health savings account dollars, could be spent on direct primary care. So direct primary care can be subscription type services. And these digital health platforms are moving into that space. So for example, the Oura Ring has a partnership with a company called SteadyMD to have clinicians oversee parts of that care delivery. So the HSA dollars going into this type of healthcare delivery is not negligible. In 2024, the estimate was that $42 billion was dispersed from HSA accounts. So it's a substantial amount of money that could potentially be used to fuel this innovation. So if you look at this equation end to end, hopefully what you see is an opportunity to scale. 190 million people with high blood pressure, 90 million people with high cholesterol. How are we going to reach those people? So if you notice here in this equation, there is no clinician, there is no cardiologist like me. There's just the likeness of me. And that, if we can do it well, that's what's going to allow us to scale. A physician or especially a cardiologist cannot see all of these patients. So I think it's sort of exciting. Of course, there's a ton of questions that need to be answered about how to do this. But in my speculation for the future, it's here. It's going to happen. So I want to leave you with one last thought. So I have I have a son who loves baseball. This summer, we watched a movie called Moneyball. And I think there's an analogy here. So this is Jonah Hill. He's playing Peter Brand, who was in charge of turning around the Oakland athletics team. And he did that with computers and statistics. He turned the Oakland A's into a winning team. And at the end of that movie, the manager of that Oakland A's team went to Boston and was trying to get recruited to the Red Sox. And the owner said, anybody who's not rebuilding using your model, they're dinosaurs. They're going to be sitting on their ass in October watching the Boston Red Sox win the World Series. And that is precisely what happened. In 2004, the Boston Red Sox won the World Series. So I think the rules of the game are changing. And that makes an exciting time to finally scale and reach all these people who need new ways to manage their health and more effective ways to manage their health. So I think the needle is going to move here. And that's an exciting time to be in the field. And with that, thank you.
So can I just make a comment? Rashmi, I was interested in the app for people getting cholesterol levels done. I do know that I have some patients who are able to go through a national lab such as Quest and actually get a cholesterol level done. And it tends to be, they can do it without the need to go see their primary or their other doctor. Do you know what the uptake is of that at the moment?
So I know the Whoop device, they're not live yet. It's called Advanced Labs. And I think there's a long waiting list for people to get on this service. I'm not sure if they've gone live with that. I think it's really early in that space. I personally love it. Now that I'm a little bit more on the patient side as I get older, it kills me that I need to order to go get my cholesterol and A1C checked. That makes no sense. So I'm all for pushing more out to the patient or end user to manage it themselves, because they don't need me to order them to get their lipids checked. It makes no sense. So I'm very excited to see where that goes.
I'd love to talk to you, Anne and Yvonne, about the role of lifestyle and food interventions. A lot of the work I'm doing at the American Heart Association is in the food as medicine space and really working to kind of further the evidence base there to make those interventions more accessible. So maybe Anne and also Yvonne, talk to me about what your thoughts are on those types of interventions and the combination with some of the other things we talked about.
Well, we have data going a long way back about saturated fat and LDL, and really a lot of this involves making small changes in some foods that the AHA has recommended a long time. We're not talking about necessarily decreasing total fat in the diet, it's just the proportions. And thus, if you change the cuts of beef, if you eat more chicken and fish, if you avoid tropical oils that, such as coconut oil, that will raise LDL quite reliably. In addition, more vegetables in the diet, more fruit can help both with lipids and with blood pressure. Less processed food, in that we want to avoid sugar-sweetened beverages. We want to avoid a lot of simple carbohydrates that can push up blood sugar and triglyceride levels and contribute to weight gain. I think that the data are quite robust. It's just a matter of making sure that people have the right information. There's a huge amount of misinformation about food on social media. And when one goes to Instagram and sees various, quote, influencers talking about this, who are not dietitians, who are not physicians, who push out things such as seed oils are bad. There are no data that seed oils are bad. In fact, high polyunsaturated oils can actually lower LDL and triglycerides. So there's a lot of work to be done. The other issue is how much exercise, when to exercise. There's a lot. Again, we have fairly nice data showing a benefit of all of these things. It's just a matter of getting the correct information available and for people to believe the correct information.
Yeah. Well said. Well said. Yvonne?
Yes. So just building on that, in terms of prevention of hypertension and management of hypertension, we have what we call the DASH eating plan, not a diet. And I actually like that we refer to it as an eating plan, because it doesn't require any special foods or strict adherence to a diet per se, because we know that most diets don't work, right? So if we can identify an eating plan where, as Anne mentioned, that we're eating more fruits and vegetables and whole grains, and choosing low dairy products. And one thing I also want to touch on is sodium, right? We know that when it comes to hypertension, lowering sodium intake is one of the proven strategies to prevent and control hypertension. Now, the goal is less than 2,300 milligrams and ideally less than 1,500 milligrams, but the average American consumes more than double that on a daily basis. So for me, apart from talking about what we put on our plate, how can we also partner with the food industry to make our foods healthier? And I say that because in the context of processed foods and even the foods that our children eat and foods that they are fed in schools, right? There are a lot of factors that sometimes are beyond an individual's control. So how can we work to lower the sodium content in foods that are already processed and produced in mass quantities? Now, this is a national forum. And as we think about strategies, I also like to think beyond sort of individual level strategies. What can we do as a society to improve access to healthy foods, but also make the healthy foods affordable, right? We talk about fruits and vegetables, but there are a lot of communities where There aren't grocery stores where one can purchase fruits and vegetables and adhere to the 5 servings of fruits and vegetables a day. For a lot of people, this is beyond reach. So as we have these conversations, I love that we're also thinking about how we can, work on policies that will make some of these healthier foods more accessible to all Americans.
Yeah, I'll pick up on one point there. When I've given similar talks in the past, I often used to end my talk with the idea that apps will not make people healthy. It's the food supply, it's the built environment. And I did not include it in this one. And the reason I didn't is because the way those things are going to change, I wonder how much of that change is not going to come from policy. It's going to come from market pressure. Like there needs to be market pressure to change those things. Otherwise they won't change because this is a, capitalistic society and you need to create and how do you create that sort of pressure? I'd love to get people's thoughts about, I think I see 2 sort of possibilities where there could be some market pressure. One is alludes to the things I spoke about, which is creating a scaled way to deliver reliable information so people know what they should expect in their foods or what they should expect with their health. That will create some market pressure. And the other is the GLP-1s. A huge number of people on those GLP-1s are going to change what they eat. So I think there are 2 ways we can sort of exert market pressure for these changes, because I'm not totally hopeful it's going to come entirely from policy.
Well, I think with policy, you have to have people agree. And I think we have, in many cases, a lot of disagreement in spite of the data. And I think part of the problem is that people do not believe in data anymore in many cases. And so it's up to all of us, I think, to really promote that and to have conversations with patients and empower patients and our community members as well. Community members saying, listen, this is what we need. Why don't we have it? And work on policy.
Yeah. Yvonne, you've done so much work at the community level and working with stakeholders across those kinds of groups. What would you maybe add about community-based programs and interventions you've been involved in and where you might see some promise here as well?
Thank you, Juliana. Really, that's where my practice is. I don't see patients at the bedside. My practice is in the community. And for me, I think there are so many opportunities to take all of this amazing expertise in a lot of our health systems. And people use the expression, meet people where they are, but it's the right thing to do because that 15-minute encounter is not enough for most people to really understand what it means to prevent hypertension, what it means to control cholesterol. So really partnering with community-based organizations and being more visible in faith-based communities. I'll give one example. We did a screening at a church in Baltimore, and there was a gentleman who was a firefighter who just retired. And he told me his blood pressure has always been great. He runs about, 5 miles a week and is very active. And since he retired, his blood pressure has just started increasing. And so we started talking. He said, well, you know what? He's started binge watching this show, and every night he has a cup of chicken noodle soup, right? So that was his comfort food. Because he retired and had started watching this show, every night he would start, he'll get a cup of chicken noodle soup. And then we talked about the sodium content, and he was shocked. He said, I didn't know, chicken noodle soup was so high in sodium. So that's an example of education, right? Teaching people to read food labels. Like when you purchase a can of soup and you look at the ingredients, if it starts with sodium and there are 800, 900 milligrams of sodium in that can, know that you already have used up majority of your quota for the day. So I think communities are where we have an opportunity to do a lot of education, promoting awareness about home blood pressure monitoring, promoting awareness about prevention, right? I think if we think about the 120 million Americans who have hypertension, there's another 120 million who don't. So what are we doing to prevent that progression to hypertension? I feel like we don't spend enough time talking about prevention. People who may be in the stage 1 hypertension or elevated blood pressure range, where we just wait and see. And then those individuals over time progress to stage 2 hypertension. We need to invest more in preventing hypertension and partnering with communities to reverse that trend towards stage 2 hypertension.
Maybe another thing to pick back up on is this issue of getting trustworthy information out to the public, and this, and kind of combating the misinformation in that space. Rashmi, you gave such a powerful example of kind of quickly leveraging technology to put together a very simple patient-focused video. Do you have other thoughts on how we can leverage these new technologies for good in terms of combating the misinformation and getting out the credible science in consumer-friendly ways?
Yeah. I mean, one thing I mentioned but didn't go into is the physician was not in that equation. And ultimately, somebody is going to control the narrative. And we better put ourselves in that seat. If we really, really care about solving this problem, it's unlikely to happen at scale unless we are deeply involved in the technology. And I think what that means, even in the last month or two, my opinion of how that could happen has changed. So before, you have to be part of the team, build the solution, not just be a consumer of the solution. You have to be part of building the solution. With the assumption there is that a problem needs to be solved, which I think we can all agree on. The way we're doing it today is not working. Now, I actually think, because of all the AI tools, I think clinician builders need to start building. It is much, much easier today to build an app. Anybody can do it with human language. All the tools that AI, you just write a prompt and it'll give you a whole set of code. You just have to get a little out of your comfort zone. So instead of trying to partner with the people doing it, which is really important, there is going to be an emerging opportunity to just build the solution yourself. And I would love to see that, because if you can properly use all the AI tools to build software solutions or other types of solutions, the dependencies on other places really, really goes down. And that's going to help us scale and kind of more effectively control the narrative, if that's what we want to do.
Dr. Goldberg, did you want to add to that?
Well, I think that part of it, and one of the reasons that the National Forum is so great, is that what we really need to do is all get together and work on both information dissemination, community engagement, and in fact, we really need to all be involved in public policy. I think that, clinicians all need to work together. I mean, a team's approach is good when in the individual practices, but in fact, I think we actually need to work across multiple areas, multiple venues, multiple public health programs. And we also need to elevate public health again to where it needs to be. It has taken a lot of hits over the last few years, and I think it is up to us to get it back.
Well said. Well said. I'll go in maybe in a slightly different direction, focused on the clinician. This is a really exciting, for me, it's a really exciting several months or about a year with the new hypertension guideline coming out just a couple months ago. We have new guidelines coming out in lipids and cardio, kidney, metabolic health, and then primary prevention. I feel like this is this year of new guidelines. Thoughts on what we can and should be doing to ensure clinicians are getting the latest guidelines and really able to kind of rapidly integrate them into their practice. We know that it's going to be a lot of new information coming at them, in sequential order. So any thoughts from this group on what we can do better to equip clinicians with this new stream of guidelines?
I think that some of what Rashmi has talked about is the whole use of technology to make the guidelines more accessible. So you put the guidelines in the electronic medical record, you provide apps to clinicians that they can use on their smartphones, which they carry around with them all the time, and say, okay, here's the prevent equation, here's your risk, this is how we do it. And other apps that make life that integrate the guidelines into the technology, because you have to have it right in front of people as they're talking to patients or even giving talks or talking to communities.
Yes, and I'll just add that you're touching on an important point, which is implementation, right? So writing the guidelines is the first step, but what is it going to take to implement these guidelines? I'll use the 2025 hypertension guidelines as an example. So there is a recommendation, class 1 recommendation, the highest level, that for adults with uncontrolled hypertension, team-based care is recommended to achieve blood pressure control. We know that there's so much hypertension to go around, with 120 million people affected by hypertension. So if we want to implement team-based care, what are some of the things that will support with implementation of team-based care? Health systems are not going to engage community health workers and nurses and managing blood pressure if that care will not be reimbursed. So as we think about the strategy and implementation of team-based care, for me, I'm very interested in how we can take the evidence that exists and accept the evidence and do the work to allow more healthcare professionals to join this effort to control blood pressure. I think a lot of the turf wars are harmful to patients, especially those in rural areas where there may not be a primary care physician. There may not be an amazing cardiologist like Dr. Shah, right? So what does it look like to still improve access? How do we leverage technology, and how can different healthcare professionals partner? It's all about partnership. I think when we center all of our efforts on patients, that's when we win. So it's a great point, and I think that we all need to find ways to advocate for policies that will allow us to implement team-based care.
Okay, well, this has been a really fascinating and exciting discussion. I think we've all taken away a lot of really important points about how we can better manage these risk factors in the community, how we can support clinicians and patients, and a lot about what's on the horizon in terms of innovation that's going to make it easier for patients and clinicians to get these risk factors under control. Thank you all for your time.
Juliana, thank you for leading the panel and for allowing me to join you now to co-lead the Q&A session. It's going to allow us to take advantage of your role as an expert and not just a facilitator. I loved in that panel how there at the end with Yvonne's comment about what's needed, the incentives, the reimbursements to support team-based care. It ties in so well with the discussion with the last panel and throughout the day, something that we desperately need. Dr. Knight, glad you were able to rejoin us from clinic. Thank you very much. And great panel, great discussion. So we have lots of questions. Some of them are sort of micro questions about what a patient might ask or wonder about. But I want to begin with the confluence of conditions that are in front of us right now. New technology, new guidelines, new treatments to manage risk factors. Juliana just talked about her excitement from all these new guidelines now. When you take these things together, is this a moment for cardiovascular and metabolic disease prevention?
From my perspective, it absolutely is. And I think one of the things that I get really excited about is as these guidelines are coming out in this way, it's the interconnectivity of these conditions and the way we can simplify for the patient who might be feeling as though in the past their conditions might have been managed in silos. And so to me, one of the messages we're really working on is how can we help simplify to the patient how all of these conditions are interconnected and how we can treat the whole person in this way. So that's one of the things that I get really excited about, and how these guidelines are coming together and how the system is starting to move around the patient in an even more centered way than maybe we've seen in the past.
Okay, so Juliana says, yes, this is a moment for cardiovascular and metabolic disease prevention. Anybody disagree?
I would agree
Okay.
with that. I think that not just guidelines, but actually what some of the therapeutics that we have now really can target multiple conditions, including things like obesity. And when you start dealing with that, you start dealing with the hyperlipidemia, you start dealing with the hypertension and the diabetes and everything else. So I basically tell a lot of my patients, this is all one problem, but we need to approach it in different ways.
Yes. So with the agreement that this is a moment and moments are time limited, right? How can we capitalize on it before people's attention turns to the next thing? Dr. Knight, what say you? You're on mute.
We don't want it to be the flavor of the week or of the month, right? And so how do we
Right.
incorporate this into comprehensive patient care? When we talk about prevention, it's not just primary prevention, secondary, it's tertiary. So whether I'm seeing a patient who is worried about heart disease because it runs in their family, or someone who had a heart attack 3 months ago, there are new therapies that add to our existing armamentarium. And that's what's really exciting about this. A lot of what we're seeing is not to replace what we have. It's actually adding synergistically to continue to reduce that risk. And so when we think of residual risk, right? So I'm doing everything, I'm following all the guidelines, but my patient still has a risk of future cardiovascular disease. What we are seeing now, whether it is obesity treatments, whether it is dealing with diabetes or directly on lipid or other cardiovascular issues, what we're seeing is further reduction. And I think that's very exciting. And it's something that no one should be able to ignore in the healthcare space.
Very well said. Thank you. Yvonne, anything that you would add to that?
Just building on what Dr. Knight just said, I share his excitement and enthusiasm also about new therapies and in the hypertension space. As he suggested, there's also another tool in our toolbox to help control blood pressure, which is renal denervation. So for a lot of patients who may not tolerate medications or are taking 6 or more medications, what does it look like to offer another option in addition to lifestyle, in addition to medications, to help lower their blood pressure and reduce their risk for cardiovascular disease? So I share this excitement for newer therapies, but also not forgetting the basics, not forgetting the importance of promoting lifestyle adherence and ensuring access to medications to control blood pressure. But as he said, we need to ensure that care is integrated. If someone has hypertension, high cholesterol, diabetes, they shouldn't be running around trying to figure out who to go to at what time. Our care models need to be more integrated for a lot of Americans who have multiple chronic conditions as well.
Very well said. Thank you, Dr. Commodore Mensah. Dr. Goldberg called attention to screening and treatment gaps as problems. And I know, Dr. Commodore Mensah, you've written extensively and spoken extensively about those problems with blood pressure management too. So what actions can we take next week to solve them?
So I think you're directing that question to me as well. In terms of action, we need to implement the evidence-based strategies that we know work. In the space of hypertension, home blood pressure monitoring is one of them. Team-based care is one of them. We talk about technology and tools that are available we also need more people. It's not enough to give someone a home blood pressure monitoring device, but they need additional support in the form of a person who's going to teach them how to measure their blood pressure accurately, how to share their results with their clinicians. So we need to implement the guidelines. We need to really take all of the evidence that exists and improve access to primary care clinicians and the overall healthcare team as well.
Yeah, you mentioned team-based care as an evidence-based intervention or implementation tool. Sarah Eve Sarliker mentioned in chat standing orders for blood glucose and lipid levels. What are your thoughts about that? What about standing orders as a tool to solve this problem with insufficient screening and treatment?
I can take a stab at that one. So the bigger implication there from my read of that comment is that how do we get rid of the roadblocks or constraints that prevent people from accessing the simple things they need? Many people, everybody is, the solution is not simple, but for the many people for whom the interventions are not that complicated, how do we get rid of the roadblocks for them to access those things? One example is just, why do I need a prescription to check my hemoglobin A1C? That makes no sense. That's like kind of where I feel like there's a lot of excitement in my area of the world, the bubble I sort of live in, that we can get rid of roadblocks, right? Like, I am too expensive to manage blood pressure. It makes no sense. I'm not scalable, if I think of it that way. And we have to make it much easier for people to access things. And the way we do it today with brick and mortar, one-on-one, and if you need 3 people in the medical establishment to manage your blood pressure, that's a relatively uncomplicated case. That's a failure because it's not scalable. We're never going to reach the population if those are our solutions. But I think we're at an inflection point where it's really possible to get rid of some of these constraints and roadblocks and alter the system a bit in a way that'll help us achieve the goals we need to achieve.
Thank you. I know all of you have done extensive work on disparities in care and access to care. Pam Morris from University of South Carolina, or Medical University of South Carolina, asks, could you comment on the digital divide and access equity issues? We have about 5 minutes left, so I'll ask you to try to be brief.
I'll just say 2 things. Assumption, what we're doing today is not working. And finally, tech and digital will help us do something differently to solve this problem. We're not going to worsen the problem. The problem is really bad today. The digital and tech stuff is going to help us solve the problem, is my position, if we do it well.
I think, though, that the problem is access. I agree with Pam in that internet access is not available everywhere in the country. There are rural areas that don't have it. That infrastructure could be dealt with. We could do that. And then other ways of teaching people. So I have elderly patients who cannot manage my chart and who have trouble with their phones. And so it's going to require a lot of education. And I think it's going to require a lot of money, which, depending on whether that's forthcoming.
Michael, I'm going to ask you, and sorry, I didn't give you a heads up on this, but I'm going to ask you to wear your National Medical Association leader hat and answer this one.
Yeah, I think it's, thinking about the burden of disease, the communities that have, are being affected disproportionately, whatever community that is, whether it's whether it's geographic, whether it is cultural. How do we meet those individuals where they are? How do we give people the tools that they need to be successful? And I think that is what we can all agree upon. If it's someone that needs technology and a technology connection, let's do it. Let's take down the barriers of having to be somewhere physically if I can connect with you on an app. But if you don't have the technology, how can I still meet your needs? If you're in a rural community, how can I meet your needs? If you don't speak English, how can I meet your needs? If you have cultural discordance and the things I'm saying are not landing with you because these are foods that you've never heard of, or these are activities that you've never done, you've never seen your parents do, how do we meet people where they are? And I think that brings us together as a part of the healthcare community to use our own backgrounds, but also to learn from each other with cultural humility so we can meet people where they are.
Yeah, I see Dr. Commodore Mensah nodding. Juliana, you sit right at the intersecting point at AHA for communication and patient education and standards for clinical practice and public policy. It all comes together there. How are you? What are you most concerned about, and what are you most excited about with respect to Pam's question about access equity?
Well, yeah, I agree with all of our panelists here that there's lots of problems to solve, and we have to be working on many different levels to do that. And so, from Anne's point, we have to work on the policy levers that are going to expand access. I think technology is moving us forward in new ways to start to decrease the divide, as maybe where it wasn't doing that many years ago. And the other strategy that AHA often deploys is our relationships at the community. So in community-based organizations and community-based supports that can fill in the gaps as well. So it's not any one strategy. We kind of have to move all the levers of our organization to work on these equity issues as technology catches up and divides, narrow. So it's a lot to be done, but I think it can be done with a comprehensive strategy.
Which takes us back to Dr. Oz's watchword in his keynote of hope, because there are things we can do. Yvonne and Anne, John Lochner asks, with medication adherence such a challenge, are there drugs on the horizon in both hypertension and cholesterol that are needed less frequently?
Well, we have definitely we have some drugs for LDL at this point that's available. Inclisiran can be done sub-Q every 6 months for lowering LDL. I think we're not quite at the point where everybody's going to be on such a medication. It's expensive when many of the other things are generic and cheap. As far as there's also some other medications with regard to severe hypertriglyceridemia that are also going to be once a month or once every 3 months or thereabouts. And LPLA drugs are coming, that is once every 6 month or once every 3 month injectables for that. So there are things that are going to be helpful for decreasing risk overall, but I don't think we're going to totally get away at this point from the readily available generic, inexpensive day-to-day medications for hyperlipidemia.
Great.
Right. And
Dr. Commodore Mensah.
And just building on that in the context of hypertension, I'm not aware of any long-acting antihypertensive therapies in terms of medications in the pipeline, but what we do have is renal denervation now, and in the guidelines, the 2B recommendation that in some patients who have resistant hypertension or are unable to tolerate medications, this may be an option. And I do think that this also addresses the issue of medication adherence, because we know that almost in 50% of people who are diagnosed with hypertension, they are non-adherent to their therapy. And for most people who are prescribed blood pressure lowering medications, they work. But in some people, they just cannot take them because of different reasons, or their lifestyle. They may always be on the road and just struggle a lot. And in those patients, we still need to offer options to lower their blood pressure and reduce their risk. But right now, the recommendation is that it's an adjunct to lifestyle and medications, but it's another option to help address the issue of medication adherence and hypertension management.
All right, thanks. We've been perfectly on time all day. There's one more question that It's a huge question. It goes right to Dr. Shaw's wheelhouse, but I think it's important. All of you will have important perspectives. So, Juliana, if you're willing, with your permission, I'd like to give each of you 30 seconds to answer a big macro question. Dr. Shaw, you said that tech must counter misinformation, and that jumped out at me as such a timely comment with the profusion of myths and disinformation about health and medicine today. So, how can we use tech to counter it?
Yeah, it's not tech that has to counter misinformation. It's people who want to send different information need to counter misinformation. And that's gets to the idea of, the one example I gave is clinician builders. If you want to control the narrative, you got to get into that space and start doing those things. I'm sure there's a whole regulatory side to this type of conversation that there's some conversation around that, which is not exactly my expertise, but it's, you have to get in the game, right? It's the people. It's like the people who tech doesn't control it. It's the people who control the narrative.
Very good. All right. Dr. Knight, 30 seconds. How do we counter mis and disinformation?
Relationship. I think relationship building. When I meet a patient for the first time, they may believe what they see online more than anything that I can say. I have all my diplomas on the wall. That means nothing because they don't know me. We don't have a relationship. But once we have built that relationship, I will tell you, patients, particularly if we think about the COVID time, patients would come to me and said, I've heard all of these things, but I want to know what you have to say because we have a relationship. So how do we, again, meet people where they are? That's a human touch that we are not going to be able to lose or replace. Let's build that relationship and let's guide our patients, let's guide our family and friends to trusted resources so that they can achieve their best health potential.
Thank you. Great insights. Dr. Goldberg.
Well, I don't know that I could actually improve on what Dr. Knight said because it was perfect. But I think that what we need to do is we need to get people the right information, and that can either be in the one-to-one. I think we could also do it through getting some of our patients to talk to other people. So communities of patients can be really helpful. If you know somebody else who has, say, familial hypercholesterolemia, that can be extremely helpful. So the patient communities and wherever those communities are and whichever communities we can work with where they trust us.
Trust, relationships. Yeah. Dr. Commodore Mensah.
My word was actually relatability, because in addition to being a credible source, I was thinking about people being able to relate to you as the messenger. And so we really need to make sure that we're getting healthcare professionals and communities and breaking down information in a way that is trusted, but also relatable. Because if I show up in a beauty salon and I'm talking about blood pressure measurement, it has to be at a level that people can relate to and understand as well.
Excellent. Thank you. Juliana, bring us home.
Last comment. Okay, awesome. Maybe I'll take this a little bit tactically for what we are doing as an organization at the American Heart Association. That we are really drastically rethinking the way we deliver content and the way we create content in order to leverage the technology that's out there. So we're bringing in new expertise to the organization to rethink how we deliver content within properties that we own, but also really moving much more to a channel strategy. And I think this was said best, we have to meet people where they are through different kinds of channels. And so really just rethinking our entire strategy as an organization that does have the trust of the public to deliver content in new and different ways. And so we can leverage the technology, but leverage the science folks, the leaders and volunteers of the organization to push that content out there in new ways. So it's a topic we are talking about within the walls of the AHA every day, because we know we have a great moment, but we have to rethink how we do it to make it happen.
Thank you. Well, it's a huge challenge that it'll take all of us to meet it, and concerted effort by all of us. Well, gosh, Ann Goldberg, Yvonne Commodore Mensah, Rashmi Shah, Michael Knight, Juliana Crawford, y'all have shared really valuable insights. I'm pretty sure I gained a couple of IQ points by listening to y'all. So thank you from a personal level. And thank you so much for being here and participating in the 2025 National Forum annual meeting. Thank you to all of our speakers today so far for your thoughtful presentations and engaging so meaningfully in the discussions.